Hi, Dr. Reagan Robertson, CCO of Productive Dentist Academy here, and I have a question for you. Are you finding it hard to get your team aligned to your vision, but you know you deserve growth just like everybody else? That's why we've created the PDA Productivity Workshop. For nearly 20 years, PDA workshops have helped dentists just like you align their teams, get control of scheduling, and create productive practices that they love walking into every day. Just imagine how you will feel when you know your schedule is productive, your systems are humming, and your team is aligned to your vision. It's simple, but it's not necessarily easy. We can help. Visit productivedentist.com/workshop. That's productivedentist.com/workshop to secure your seats now.
The same thing happened. They'd go to another local lab and have them check it. It would come back and it just wouldn't be exactly a perfect match. And that's very frustrating for the dentist, but even more so frustrating for the patient, because what do they think during that time? What are they thinking as you're trying it in for the third or fourth time? They think you don't have a clue what you're doing. They think you are, one of the worst dentists. And it's just, they think you just don't know what you're doing. So how do you alleviate that problem?
Hello, everyone. This is Dr. Bruce B. Baird, and you're listening to the Productive Dentist Podcast. In this podcast, I will give you everything that I've learned over the last 40 years in dentistry, working with thousands of dentists. I'll tell you, it's not that my way is the only way. It's just one that has worked extremely well for me, and I'd love to share that with you so you too can enjoy the choices and lifestyle that productivity allows. More time for things you love, increased pay, better team relationships, and lowered stress. Let's get into it with this week's episode of the Productive Dentist Podcast.
Hello, this is Dr. Bruce Baird of the Productive Dentist Podcast, and today we're going to talk about the fourth risk factor, which is aesthetic risk. And what do we mean by aesthetic risk? Well, when you have a patient that smiles and they don't show their teeth at all, that's what you would call a low aesthetic risk. Somebody who you could almost have any laboratory do the dentistry for you. You could have them, you could have a crown that's a different color. You can have crowns that have a metal collar to them. Patients or other people are never going to see it on that patient. So what's the high aesthetic risk patient? Well, that's when they smile so big, they show their gums, and as I'm going through the risk factors with these patients that are high risk, I truthfully don't even talk to them about it if it's low risk, because it's not a big deal. But when you have a high aesthetic risk patient, it's imperative that they understand that they're high risk. And I'll tell you, I go back 30 years and I'd have that patient with a big smile come in, and I would go, they had broke their front tooth, and they would say, "Can you fix it?" And I would say, yeah, we can fix it. It's going to be great. I use a great lab, and these guys are amazing, and they're going to do a great job. And as a matter of fact, the guy who developed the Sunrise Crown was my ceramist back years ago, with gold, with porcelain on it, and did beautiful work. But what we would do is I would take my shades and I would prep the tooth, and we would go have the crown made. And it would come back, and sometimes it'd be right on. But as many of you know, you put it up there and you go, darn, I didn't catch I didn't get the right chroma on this. It's a little too bright, or it's a little too down. And so I would tell the patient, I said, you know what, let me send it back to the lab. Let me make a change on this, and I would tell them that. And we would get it back, and it still wouldn't be quite right. I don't know if this has ever happened to you, but, and so maybe the third time you're sending them to the lab, and they're doing the custom stain job right there in the office. And Danny was great at doing that, but when he passed away at a young age from pancreatic cancer, so I lost my ceramist. But the same thing happened. They'd go to another local lab and have them check it. It would come back and it just wouldn't be exactly a perfect match. And that's very frustrating for the dentist, but even more so frustrating for the patient, because what do they think during that time? What are they thinking as you're trying it in for the third or fourth time? They think you don't have a clue what you're doing. They think you are, one of the worst dentists. And I mean, it's just, they think you just don't know what you're doing. Now, so how do you alleviate that problem? Well, I'll very simply, in talking to the patients about risk factors, I explain to them that they're a high risk. And I'll say something like, Maggie, when you smile, you see everything. You can see your gums, you can see your teeth, you can see the edges of your teeth. So when we do this dentistry for you on your front teeth, it has to be perfect. I mean, it literally has to be perfect. Now, I have some patients, Maggie, when they smile, you can't even see their teeth. Well, you're not one of those. And so I have options as a dentist at that time. I used to charge 1.5 times the cost. So if a crown was $1,000, I would charge $1,500. If it was $800, I'd charge $1,200. And I tell the patient, your teeth are going to be a little more expensive because of that high, big smile that you have. It's got to be perfect. My commitment to you is to make sure that it's perfect. Now, it may take us longer. It may not be an overnight deal. We may have to send you to the lab to have it done. We may have to, it may take 3 or 4 appointments. So having said that, now the patient knows it may take 3 or 4 visits in order to get this done correctly. And what does the patient think when you get it done the first visit or the second? First of all, they know they're very difficult, but you know that you're committed to giving them what they need, which is a beautiful crown that you can't tell the difference between it and the teeth around it. Now, I've been very fortunate. I've been using CEREC technology now for, as most of you know, for years. But I didn't do a lot of anteriors until probably the last 8 years. And the software has gotten so good, and I'm able to pick blocks. I've learned to do custom staining myself. And so when I'm sitting there with a CEREC, and I've told this patient that it's going to be extremely difficult. I don't care if you're using E4D or whatever, scanning and sending it to a lab. I don't really care. But my advantage over the competition, the other dentists around, is, first of all, I can do the crown in one visit, but I can also do custom staining, and I can do it where the patient is watching me. And so now they look at it as, wow, I mean, Dr. Baird and his team, man, they really know what they're doing. And they go out, and when they start talking to other patients, they're saying, oh, you've got to go see them, because they can do the staining. And, some people have a big, high smile. They're actually talking about risk factors to their friends who they know have had dental issues. So it's an absolutely amazing practice building tool to be able to do it right there chairside. Even more so, it is the opportunity to set yourself apart, from other dentists. And I'm not trying to take anyone else's patients, but what I will tell you is I'm going to do the best dentistry that I can possibly do. If I'm not good at staining, I'll go to staining courses. I'll go learn. I'll go to Vita. I'll go to, whoever I need to go to learn how to do it. And that's what I've done over the years. There are actually some AACD fellows that were lab technicians before they became dentists. So they've learned how to do that. Now, anybody can learn it. It just takes some time. So these are the things that I look at when we are, talking about the high aesthetic risk patient. The other thing that you have to look at is, what about that patient that's a high aesthetic risk that is losing their teeth? From a denture standpoint, they're going to lose their teeth, or what I call terminal dentition. They're going to lose them. You have to be very, very aware in taking impressions on where you want that smile line to be. And so what I'll do is, when we're taking impressions for say, dentures, or whether it be immediates, whether it be, whatever it is, a hybrid bridge up top, all of these things come into play whenever you're doing these more complex type treatment plans. So let's say first, if it's a denture first, well, that they're going to smile to a certain level. So you're going to want to have that gingiva starting there. But what about that hybrid bridge case? What if a person smiles with no teeth in and they show that upper ridge? What does that tell you? Well, what it tells me is, we're going to have to do, if I'm going to go with a hybrid that has to have 13 millimeters of thickness, I'm going to have to take away a bunch of bone. Now, does that bother me to do that? Well, not really, but I have to know that this patient, when they smile, I got to have 13 millimeters above that. So those are things that are critical. As a matter of fact, when I have a patient that has so much bone, in many cases, I'll do more of a crown and bridge type FP1 where I'll have more crown and bridge. I'll put the implants in, but it will be really no pink there because when they smile, they're already showing it. I would also rather do a little alveoloplasty so that that smile line is right at that level. I hope that makes sense. So it's extremely critical in implant prosthetics. What I've seen people, and this is something you have to be very, very aware of. You go in and you're saying, I'm just learning to do implants. I'm going to pop 4 implants up top. We're going to get rid of the roof of the mouth for you. And so you go in, you pop in the implants, and then you put your snaps on, and all of a sudden you realize, good grief. When they smile, I mean, I can see all that pink, and it just doesn't look good. How do I know these things? Well, I've done them, and I've gone back and said, you know what, I don't like the way this looks. Let's make some changes. But the bad news is if you've already put those implants in that position, you don't have a lot of places to go, without taking them out and then doing a significant alveoloplasty. So I'm looking at smile and their smile risk very critically when I'm doing any type of prosthetics that include implants, because once those implants are at a certain spot, I've gone in on patients and taken out all the implants that they've had on the upper ridge or even the lower, where I can now place implants at the right position so that if I'm going with snaps, say locators or whatever type stuff you have, I'm going to have good aesthetic results, because people don't want to look like Mr. Ed, with these teeth, big old giant teeth, and that's when they stand out. How many times have you had that happen? Often. So, or have you had people say that? Hopefully you haven't had teeth that look that way. But it's critical in implant prosthetics. The other areas that it makes a big difference is I've seen dentists, and I've had patients walk in and their teeth are ugly as heck. They said, yeah, I had implants done. They snap them out. And now what they've done is the dentist previously had put in 4 implants and made a bar, which they didn't have enough room for snaps, but now they've added another 2 or 3 millimeters in a bar with attachments. Well, even using breed-in attachments on the side where you're not adding to the occlusion, it still can be a major problem on aesthetics. So if you're doing a bar overdenture or snaps, those are great for those patients who've lost an enormous amount of vertical. But when you just do an immediate taking out teeth on somebody, you've got to be aware of those things. It's absolutely paramount and it's critical. So I had a patient years ago come in that had a maxillary subperiosteal implant in. I don't do maxillary subs. I've done probably 50 mandibular subperiosteals. That tells you how old I am. So but this maxillary sub was coming in and the thing had settled into the sinus. The patient came in, I didn't know it had settled in the sinus at the time, but I had the patient come in, and when they smiled, they couldn't even put their lips together. Guess who they were pissed off at? They weren't pissed off at the guy who did the subperiosteal. They were pissed off at the dentist who did the teeth. So I said, okay. I said, well, take those out for me. Because they had O-ring attachments on this sub. I said, take them out for me. She goes, oh, I can't take it out. I go, oh, wait a minute. Yeah, you can take it out. This lady had not taken the upper sub out since she had it done, 4 years. So I was like, okay, so we got it out. It was not a pretty picture. That's when we found out the tissues were just like minced up. But the patient was actually upset with the restorative dentist. When I took that denture out and she smiled, I could see the framework of the sub. I mean, there's no way that restorative dentist could be successful with the prosthetics being set up that way. So, just be aware of that. Aesthetic risk, it's not unusual to have patients who, when I talk to them and I explain that it's going to be more costly because of that, they understand. So I can charge a higher fee. The fact that I do pretty much all my own staining and custom staining. I usually don't even charge them that extra fee now. I could if I was trying to, nickel and dime. But if I'm sending them to a laboratory, I mean, the truth is you can send it to any ceramist in the world and have this work done as long as the patient's paying for it. I think in the past I would go, oh, I'm going to send them to this ceramist. I'd never tell them it was a different cost. And then here the bill would be, and I'd be going like, crap, I didn't even make any money on this case. And that happens a lot in the early stages in implant dentistry. I remember Paul Homily talking about, these big cases are wonderful, but there's a lot of people that aren't making money doing them. And so you have to just really be aware of those things. So anyway, that's today's risk factor, which is aesthetic. I hope you guys have a great day. Send me questions if you have to bruce@productivedentist.com. Go to iTunes, go to the store and register for the podcast. I would really love it if you do that, and tell your friends, because we'd love to have them get involved. So talk to you next time.
Thank you for joining me for this episode of the Productive Dentist Podcast. If you found this episode helpful, make sure you subscribe. Pass it along to a friend. Give us a like on iTunes and Spotify, or drop me an email at podcast@productivedentist.com. Don't forget to check out other podcasts from the Productive Dentist Academy at productivedentistpodcast.com. Join me again next week for another episode of the Productive Dentist Podcast.